So today I'm taking a class on carcinoma stomach. And first of all, go through this scenario. 60-year-old male complains of epigastric pain, feeling of fullness, loss of appetite since 6 months, weight loss, tiredness since 4 months. He gives past history of peptic ulcer disease, and on examination, patient is anemic, emaciated, and there's a lump palpable in the epigastrium. There is visible peristalsis from left to right, and there's a firm mass on palpation. The surface is nodular and moves with respiration. So other systems are normal. So in this epigastric mass, male patient, anemic, loss of weight, loss of appetite, and nowadays the patient is having vomiting. So if you get a case like this, what's your first diagnosis? It's a case of carcinoma stomach. So today we'll be learning the management of carcinoma stomach. The anatomy and all these things you have already learned in your first year class. So I'll just show you the diagrams, and you can go through all these diagrams later and find out the blood supply and lymphatic drainage and all these things. Okay. Carcinoma stomach. And coming to the divisions of carcinoma stomach, it has got a cardia, fundus, body, pyloric antrum, and pyloric canal. Then it continues as the duodenum. And coming to the vascular supply, mainly the stomach developed from the foregut. So the artery of foregut is celiac trunk. Artery of foregut is celiac trunk. So from celiac trunk, the left gastric, right gastric, gastroepiploic, right and left gastroepiploic, and short gastric arteries from short splenic arteries and inferior phrenic arteries. These are the arteries which supplies the stomach. Then coming to the lymphatic drainage, as far as stomach is concerned, there are three sets of lymphatic drainage nodes are there. One is very close to the lesser curvature and the greater curvature. There are so many nodes. You can see so many nodes, group of nodes. You can see close to the greater curvature and the lesser curvature. The left gastric, short gastric, splenic is little away from that, and left gastroepiploic, then right gastroepiploic, and right gastric. These are the nodes coming close to the margin of the stomach. Then the second node stations are the hepatic and the splenic nodes are there. Then the third station comes, that is the celiac nodes. So this is the way that the lymphatic drainage goes. Three sets of node will be there for all visceral structures. All visceral structures, it has got very close to that organ. They will have perigastric or close to that organ nodes, and later after from there the drainage will be to an intermediate node, from there to the main nodes. So as far as stomach is concerned, this is about visceral drainage of the lymphatic drainage of the organs. So when you see from the foregut, the structures from the very close to the organ, there are some lymph nodes are there. From there it goes to the intermediate nodes like gastrohepatic, gastroduodenal, splenorenal, then gastrosplenic. From there the main principal nodes, it goes to the principal nodes, that is pre-aortic, celiac, superior mesenteric artery nodes, and nodes around the inferior mesenteric artery. So very close to the visceral organ, you will get some group of nodes. From there, the lymph will be drained to the intermediate nodes. From there to the principal nodes. So when you see downwards, the pelvic organs, the genitourinary system. From there, the lymph nodes It drains to the common iliac, nodes around the common iliac, external iliac, internal iliac, and presacral nodes. From there to the para-aortic nodes. So from foregut, midgut, and hindgut, it goes to the pre-aortic celiac, superior mesenteric artery, and inferior mesenteric artery, that nodes around that area. Then node location in case of carcinoma stomach, or as far as stomach is concerned, there are more than 18 nodes are there, 16 nodes are there for stomach. First 6 groups of nodes are named like this, and first 6 nodes are, this is perigastric, that means very close to the 3 centimeter distance each 6 group of nodes will be situated, and from there 7th onwards up to the 11th group of nodes, these are situated little away from that, that is intermediate nodes, and from 12 to, these are named like this, and 12 to 16, these nodes are, these are the principal nodes. These are seen at the root of mesentery. It is seen along the superior mesenteric vessels, middle colic vessels, and around the abdominal aorta, like that. So all these are the principal nodes for as far as stomach is concerned. So try to understand this. 1 to 6. 1 to 6, that means right paracardium, left paracardium, along the lesser curvature, along the greater curvature, the pyloric, infrapyloric, this much nodes. These are named as perigastric nodes. So these are while doing surgery of stomach, we are more concerned about this first 6 group of nodes, that is called D1 dissection. That means removal of these 6 groups of nodes are called D1 dissection. Then from 7 to 11 nodes, if we are removing that, that means lymph nodes seen close to the celiac artery and the splenic artery. So if we are removing that dissection is called D2 dissection. So now you know first 6 nodes if you are removing, that means 6 group of nodes if you are removing, that is perigastric nodes. That means it is D1 dissection. If you are removing from 7th onwards up to 11 the group, that means seen along the celiac artery and the splenic artery. That means you are doing a D2 dissection. From D3 dissection onwards, that means you are dissecting at the root of mesentery. You have to go till the root of mesentery. That means on the posterior abdominal wall, to remove all the lymph nodes close to the superior mesenteric vessels and the para-aortic region. So that is D3 dissection. Nowadays, while doing surgery, we do only till D2 dissection, because we won't go up to D3 area, because that will reduce the morbidity and the complications of the surgery and the morbidity of the patient. So we always suggest D1 or D2 dissection. So that's all you have to understand from this slide. Okay. Then coming to layers of the stomach, this is we are concerned because when infiltration to the layers of the stomach, according to that only we classify, tumor classification comes. In TNM classification, the tumor classification comes according to the layers of the stomach. So you know the layers, mucosa. From the mucosa, the carcinoma stomach starts. Mucosa, then the submucosa. In between, there is a small brown layer, that is the muscularis mucosa. That is a small layer of muscle, that is the muscularis mucosa. So mucosa, submucosa, mucosa and submucosa, and muscularis mucosa is a thick layer. The muscularis mucosa, muscularis externa, muscularis externa. Muscularis externa. The other one is muscularis mucosa, and the big layer, that is the thick layer, that is the muscularis externa. It contains circular, oblique, and the longitudinal muscles. And then comes the serosal, subserosal connective tissue and the serosa, and outer to that is the peritoneal cavity and the other structures are there. So now you know the layers: mucosa, muscularis mucosa, submucosa, the mucosa muscularis externa, which contains three group of muscles: circular, oblique, and longitudinal muscles. Then subserosal connective tissue and the serosal layer. So according to the infiltration to the deeper structure, we will classify it as T1, T2, T3, T4, like that. Okay, that will come to the that slide will come later. So that is about the histology of the stomach. The magnitude of the problem in males, this is the fourth most common cancer. In the females, it is the fifth most common cancer. First one for female, it is breast, and then comes cervix, colorectal, lung, and stomach. For male, the first common cancer is lung cancer, then second one is prostate, third one is colorectal, and the fourth one is stomach. So this is the incidence of cancer, CS stomach. This is the occurrence of CS stomach in males and females. In India, Kashmir is the most common place we see carcinoma stomach. So coming to the etiology, this I have taken from SRB. So you can go through all these things. Environmental, occupational, dietary habits that leads to development of carcinoma stomach. That is smoking, alcohol intake. Daily 3 pegs of alcohol can lead to chronic atrophy of the gastric mucosa and can lead to carcinoma. And smoking, obesity, low vegetables, diet with low vitamin A and vitamin C. So you should eat more vegetables and fruits to prevent development of carcinoma stomach. Then consuming more red meat, smoked meat, cabbage, diet rich in nitrosamines, salty food material, that means more salty fish and fish preserved in salt and all. If you take that, that can also lead to carcinoma stomach. Then viral infections like Epstein-Barr virus infection, occupational like rubber and coal workers, and low socioeconomic status. Distal cancers are most common in this low socioeconomic status, because they used to get acid peptic disease and finally it can lead to gastric ulcers and carcinoma of the stomach. And in higher social group, the proximal cancers like cancers of the cardia of the stomach, it is most commonly seen in higher class people. And there are some precancerous lesions which can lead to carcinoma stomach. These are the H. pylori infection, chronic gastritis, pernicious anemia, then intestinal metaplasia, adenomatous polyps more than 2 cm. It can finally turn to malignancy. A gamma globulinemia, benign gastric ulcer, previous gastric surgery because of biliary gastritis, it can lead to carcinoma stomach. And menetrious disease, that is protein losing gastric enteropathy, that can also leads to carcinoma stomach. And there are some familial and genetic factors are there. You can go through all these things. I don't want to waste my time by describing all these things. You can go through all these things. Okay. Then I have already told you the precancerous lesions of stomach, gastric adenoma more than 2 cm size, chronic gastritis, like that. Whenever there is a normal mucosa of the stomach, H. pylori infection or low vitamin C and high salted diet finally leads to chronic superficial gastritis, leading to atrophic gastritis, and intestinal metaplasia occurs. And because of the intestinal metaplasia, the dysplasia starts because of the overexpression of COX-2, cyclin D2, and mutation of P53 can lead to development of gastric dysplasia and gastric cancer. Then histological types of gastric cancers are adenocarcinoma is the most common type of gastric carcinoma we see, now. That is 90% of the gastric carcinomas are adenocarcinomas. Very few percent, only 10% in that comes lymphoma, gastrointestinal stromal tumors, squamous cell carcinoma, carcinoid tumors, and adenoacanthoma and signet ring cell carcinoma. Signet ring cell carcinoma is the most malignant form of adenocarcinoma. It is a very malignant variety of adenocarcinoma that is called signet ring cell carcinoma. So the common carcinoma of stomach is adenocarcinoma. This is some words about signet ring carcinoma. You can just go through that. Then pathological classification. Borman classification, Laurent classification system, and WHO system. Borman classification system is the macroscopic appearance. When you do a endoscopy, you can see the growth in the stomach. So according to the growth, you classify. That means polypoid type, ulcerative type, infiltrative type, like that. So that is according to the macroscopic appearance we classify. That is the Borman classification. And according to the pathological type, that is intestinal and diffuse, like that. That is the second type of classification, that is the Laurent classification and WHO system. So Borman classification, this is the picture. Borman classification. Borman is based on macroscopic appearance, useful as endoscopic finding. Polypoid, that is type 1. Ulcerative, type 2. Infiltrative and ulcerative. Both infiltration and ulceration seen, that is type 3. Diffuse infiltrative, that is type 4. Cannot be classified under, that is type 5. So these are the types of macroscopic appearance of carcinoma stomach. That is according to the Borman classification. Polypoidal, ulcerative, infiltrative ulcerative, diffuse infiltrative, and cannot be classified. The protruded variety is type 1. All depressed varieties are type 2, 3 and 4. So coming to second one is Laurent's classification. Laurent classification is according to the pathology type. So the difference between Laurent's in Laurent's classification comes the intestinal type and the diffuse type. So intestinal type is the best thing you can have. The diffuse type is more malignant. That is mostly seen in type A blood group patients, blood group people. It is a familial variety. It is more seen in females. In the younger age group, it is poorly differentiated. That means it is the prognosis is very bad. It's spread by transmural and lymphatic spread. But in case of intestinal type, it is an environmental type. That means according to the food intake and all, we get this type of carcinoma, intestinal type. And it's seen more in the males, maybe because of alcohol intake, I don't know. Increasing incidence with the age. As the patient age increases, this type of carcinoma comes. It's and it is spread by hematogenous spread, and it is an exophytic bulky lesion. The other one, this linitis plastica, it's a type of carcinoma stomach. In this, the whole intestinal wall is involved. So that is the whole intestine, not the intestine, the stomach wall is involved. That is called linitis plastica. So it is an ulcerative lesion, frequent intraperitoneal meta, because I have already told this, a poorly differentiated carcinoma, that is the diffuse type, is very, very bad prognosis. Diffuse type and intestinal. So Laurent classification, diffuse type and intestinal type. Coming to WHO classification. WHO classification, it is classified on morphological features. Adenocarcinoma, it is according to the growth pattern, papillary, tubular, mucinous, and signatory. And adenosquamous cell carcinoma, squamous cell carcinoma, undifferentiated, undifferentiated and unclassified. These are the WHO classification for carcinoma stomach. So, three types of classification. One is Borman, that is according to the macroscopic appearance. Lawrence according to the microscopic appearance, and WHO classification. See, there are the three types of classification for carcinoma stomach. Then coming to the clinical features, most of the patients are asymptomatic. 70% of the patients are asymptomatic. When the symptoms start, that become advanced stage. So, in that case, I want to tell you that when the patient is maybe having some gaseousness abdomen like that, it's better to go for a screening test like endoscopy. So, in that time, we can find out an early lesion. If the symptoms are more aggressive, when the as the time passes, the patient will be having more symptoms, and there will be infiltration deep to the muscles and serosa. At that time, the patient develop features of obstruction and bleeding like that. At that time, it is an inoperable case. So at that time, it became an advanced disease at the time of diagnosis, because the symptoms are always non-specific. Patient എപ്പോഴും പറയും ഗ്യാസിൻ്റെ അസുഖം. So they will take some medicine for gas and they will go on like this. Finally, the patient will end up with a advanced disease. So patient sometimes the patient may have epigastric pain, nausea, vomiting, early satiety, weight loss, GI bleeding. Because of GI bleeding, patient may have anemia. Sometimes can present with hematemesis. Mostly the patient is anemic because of the bleeding into the GIT, slow bleeding. So patient may not be knowing all these things. So patient will come with anemia, and on investigation only we will find that patient is having CS stomach. Then the patient can have, if the bleeding is more, the patient can present with melena. Sometimes the patient can present with a palpable mass, especially in linitis plastica. A patient comes with a mass in the epigastric region. And sometimes patient may come with enlarged left supraclavicular node, that is Virchow's nodes, or it is called Trousseau's sign. You can see the node here between the two heads of sternocleidomastoid. And Sister Mary Joseph node, that is in advanced case, patient may come with a nodule in the umbilicus. So how these malignant cells reach here? From the stomach, it infiltrates from the through the lymphatics, it can reach the hepatoduodenal ligament. When it reaches the hepatoduodenal ligament, it can approach ligament of teres. From the ligament of teres, it can reach the umbilicus. That is how patient develop secondaries, or patient develop a nodule in the umbilicus. That is called Sister Mary Joseph nodule. Another finding is Irish nodule. That I will tell you later. Sometimes the patient will come with hepatomegaly, jaundice, ascites. In all these cases, the patient will be having metastatic disease. The Krukenberg tumor, that is the tumor developed in the ovaries because of the metastasis from the stomach. Or Bloomer's shelf, that is frozen pelvis, like that deposition in the just both sides of the uterus, retrovesical pouch, retrouterine and retrovesical. Irish node, that is the enlarged left axillary lymph node. You know how this left axillary node is enlarged? That is also through lymphatic spread from the abdomen through the thoracic region. It reaches the axillary region. So that is the spread noted in carcinoma stomach for a enlarged lymph node in the axilla. So that node is called Irish node. How the carcinoma stomach spreads? 5 types, 5 modes of spread. One is submucosal spread through the wall. Horizontal spread along the stomach wall, that is the submucosal spread. From the mucosa, then from there to the submucosa, it spreads like that. So the diameter of the swelling increases. Vertical spread, that is invasion of the stomach wall from mucosa to serosa. That is the vertical spread. So that immediately it reaches the, gradually it reaches the till the serosa. From there it infiltrates on the pancreas and colon. So that is the vertical spread. Then lymphatic spread. First to the perigastric nodes, from there to the celiac and hepatic and splenic nodes, from there to the nodes along the gastroduodenal and that to the root of mesentery and para-aortic nodes. Then peritoneal dissemination through the peritoneum, it can spread. Through the blood, it can spread. The malignant cells can spread to liver also. Then alarm features suggestive of gastric cancer. So whenever you feel or if the patient complains of all these things, you have to think about gastric carcinoma. These are the alarm features suggestive of gastric cancer. No onset of dyspepsia in patients more than 55 years of age. Family history of upper GI cancer. When the patient complains that the patient's relative, somebody is having this family history of GI cancer, then you have to suspect with all the symptoms of anorexia, asthenia, anemia. All these symptoms the patient is having, that time you have to suspect gastric carcinoma. Unintentional weight loss, upper and lower GI bleeding, progressive dysphagia, iron deficiency anemia, persistent vomiting, palpable mass in the epigastric region, palpable lymph nodes, jaundice. When you see all these features, you have to suspect gastric carcinoma. Then coming to the staging, so we are going for TNM staging. Just like any other tumor, AJCC TNM staging. T is tumor invasion, N is lymph node involvement, and M is metastatic disease, presence or absence of metastatic disease. The number of node involvement and the depth of tumor invasion. So I have already told you the layers of the stomach: mucosa, muscularis mucosa, submucosa, muscularis externa or muscularis propria, subserosal connective tissue, and serosa. So these are the layers of the stomach. So when you TX is primary tumor cannot be assessed. T0 no evidence of primary tumor. Then T1, when you see on the diagram, top of that diagram, you can see T1, T2, T3, T4. T1 is involvement of the mucosa. That is T1A, only mucosa is involved. T1B, that is submucosa is also involved. When you go for the horizontal spread, the tumor from there, it goes to the only to the submucosal layer. That is the horizontal spread of the disease. So T1A means only to the mucosa. T1B means to the submucosa also, involvement of the submucosa also. Always T2 means involvement of the muscles. There are 3 layers of muscles are there in the stomach, and involvement of the muscle layer starts in T2. If it has involved the muscles, we will classify in T2 group, T2. And T3 is involvement of the whole muscle and the mucosa and the submucosa, the connective tissue in the serosal layer. And T4 is involvement of the serosa and to the spread to the surrounding structures. So T1, T2, T3 and T4. T1 is involvement of the mucosa. T2 is infiltration to the muscle layer. T3 is the whole layer of the muscle is involved till the serosa, and T4 is involvement of the serosa and up to the serosa and to the surrounding structures. So T3, so that is all about T3 is gastropolic and hepatoligament lesser. Okay. When the this is involved, T3 means it is involved up to the serosa. So there comes the greater and the lesser omentum. And the hepatic ligament, gastrocolic ligaments are coming close to that region, up to the zero, that is very close to the serosal layer. So in T3 case, there is involvement of the greater and the lesser omentum, and the gastrocolic and the hepatic hepatoduodenal ligaments are also involved. So T1 is involvement of mucosa only, T2 is involvement of the muscle, T3 is involvement of the whole thickness of the stomach including the serosa, T4 is involvement of the surrounding structures also. So now you know the tumor T classification, T1, 2, 3 and 4. Then comes the nodal classification. N1 is 1 to 2 regional lymph nodes are involved. Not all the perigastric nodes are not involved. Only 1 or 2 cardiac or right gastric or right gastroepiploid. 1 or 2 regional lymph nodes are involved. Then N2 is metastasis in 3 to 6 regional lymph nodes. That means enlarged 3 to 6 lymph nodes. That means all perigastric, there are 6 nodes are there. I have already told you first 6 nodes are perigastric nodes. So in that 1 or 2 regional lymph nodes involved means that is N1. That is N2 means metastasis 3 to 6 regional lymph nodes. N3 is metastasis in 7 or more regional lymph nodes. In that N3A 7 to 15 nodes involvement and N3B is 16 or more nodes are involved. So now you know what is N, that is nodal involvement. N1 is metastasis in 1 to 3 regional lymph nodes. N2 means metastasis in 3 to 6 region. That means all perigastric nodes are involved in N1, N2. Perigastric nodes are involved in N2. So when the patient is having N2 staging, N2, then you have to go for dissection D2 because all perigastric nodes are involved. So you have to go little higher up. That means the nodes along the celiac trunk and the splenic artery, close to the splenic artery, that is D2. You have to remove that nodes also. So that is called D2 dissection. That means you are removing the N1, N2 and N3 nodes. N3 means metastasis in 7 or more regional lymph nodes. In that, if it is 7 to 15 nodes are involved, that is N3A. That means at the root of mesentery, involvement of the lymph nodes at the root of mesentery and hepatoduodenal ligament, that is N3A. N3B means close to the aorta, the nodes along the course of aorta, that is N3B. Then about the M, distant metastasis. Whenever there is distant metastasis, M1 metastasis to the distant organs, then we will call it as M1. So coming to the staging, this I have taken from SRB. So you can go through this. Stage 1A, that is T1, but no nodal involvement. N1 means the lesion is confined to the mucosa, but there is no nodal involvement. 1B means there again T1, that means only mucosal involvement or just touching the muscles, but no nodes are involved, no metastasis. Then stage 2E, in that mucosal involvement with N2, that means perigastric nodes are involved. T2 means involvement of the muscle layer, and one or two groups of perigastric nodes are involved, or up to the serosal involvement with no nodal metastasis. So I can go through this stage. Okay. So stage 1, 2 and 3, these are called locoregional disease, and stage 4 is systemic disease. Stage 4 is any type of tumor, any size of tumor, any nodal involvement, but there is metastasis to the other regions. So that is stage 4. Stage 1, 2 and 3 is locoregional disease. Only T1 and T2 lesions are operable lesions. So what is T1 and what is T2? T1 is involvement of the mucosa, and T2 means just it has infiltrated the muscle layer. So T1 and T2 lesions are operable lesions. To get a better survival, you have to add chemotherapy also. After surgery, this is an operable lesion. So you have to do surgery for these T1 and T2 lesions, and after that, post-operatively, you have to add chemotherapy also. In that case, the survival rate is very good in these cases. For what about T3 and T4 lesions? T3 and T4 lesions means T3 means involvement up to the serosa. T4 lesion is involvement of the surrounding structures also. So in these lesions, we prefer a palliative procedure plus chemoradiation. So now you know what is the treatment for T1 and T2 lesion. Whatever be the nodal involvement, T1 and T2 lesions are operable lesions. But after that you have to add chemotherapy. But when the serosal involvement or to the surrounding tissue infiltration is there, it is better to go for a palliative procedures, because it is very difficult to separate the stomach from the stomach bed if the patient is having a T3 or a T4 lesion. And that time you can don't go for a curative surgery, you can go for a palliative procedure. That what all the palliative procedures I will tell you later. And after that you have to add chemoradiation. You are giving a palliative procedure, you are doing it just an anterior GG or something like that, just to relieve the obstruction, that's all. So after that you have to give chemo and radiation. So what all investigations you do in case if you are suspecting a case of carcinoma stomach? So first of all, we know the gold standard is upper GI endoscopy and take a biopsy. If you see a lesion there, you can Borman classification also you can classify, and you can take biopsy from the lesion. 10 targeted biopsies are taken. And if you see a lesion there, you want to see whether the patient is having any metastasis, or what is the size, what is the extent, it is infiltrated up to which layer, like that, node status, all these things you will get it by doing a CECT of the abdomen. And now the modern technique, that is the EUS. EUS is an endoscopic ultrasound. So while doing an upper GI endoscopy itself, the patient is having a lesion. If they found that a lesion in the stomach, that time they can do an endoscopic ultrasound. So in endoscopic ultrasound, it is 90% accuracy for tumor staging and 80% accuracy for nodal staging. So through through the endoscopy is passed through the esophagus and to the stomach, and do an ultrasound, so that you can see all layers of the stomach. You can see layers of the stomach as 5 layers, and in that the tumor also you can see, and up to which layer it has infiltrated you can find out very clearly. So 90% accuracy is there for EUS. And perinodal status also you can make out 80% specificity is there. So if you from the node also you can take FNAC while doing this EUS, and you can take a biopsy from the tumor also. So it is a very good investigation procedure, EUS. Even you can replace other MRI and all these things because it's very very accurate. Then barium meal study. It is not mandatory for all carcinoma stomach to do a barium meal study, but in case of linitis plastica, you have to confirm your diagnosis by doing a barium meal study, because while doing endoscopy you will not get a you will not get any findings in mucosa. So in barium meal study only you will get some finding to diagnose linitis plastica. And barium meal findings in carcinoma stomach: irregular filling defect if it is an ulcerative lesion or a polypoidal lesion, loss of rugosity, delayed emptying if there is a lesion in the lower part of the stomach or in the pyloric region, dilatation of the stomach in carcinoma of the pylorus, decreased stomach capacity in linitis plastica. It is a leather bottle stomach. It is called leather bottle stomach. The capacity, the space on the stomach is very much diminished in case of linitis plastica because of the increased thickness of the stomach wall. The margin of the lesion projects outward from the ulcer uh, into the gastric lumen, that is called Corman's meniscus sign. So these are the barium meal findings in carcinoma stomach. So all these things will be asked when you come for the viva, and if you give an X-ray of barium meal like that, they will ask about what are the barium meal findings in carcinoma stomach. The next investigation is USG of the abdomen to see whether the patient is having any ascites, liver metastasis, ovarian metastasis like that. Then you can take a FNAC. If the patient has come with a left supraclavicular clavicular lymph node enlargement, you can take an FNAC. And of course, you can do some blood tests, CBC, because anemia patient, you can demonstrate that patient is having anemia. LFT, deranged LFT is a feature of liver metastasis, and tumor markers like all these tumor markers, CEA, CA19, C72-4, CA12-5, all these are the tumor markers for carcinoma of the stomach. And the last one is the diagnostic laparoscopy. Diagnostic laparoscopy, you will get all the findings, whether the stomach growth is visible or not, whether the patient is having ascites, peritoneal mets are there, whether the is an operable case or not, like that. And while doing this diagnostic lab itself, the patient is having a operable lesion. At the same time, you can do a surgery also, laparoscopic gastrectomy, distal or subtotal or a total gastrectomy like that you can do at the same time also if you plan and go. So while doing a diagnostic lab, you can stage the tumor, you can see the tumor, and if it hasn't penetrated